This episode of the Jerry Paul Podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Paul Podcast. This is Eric Woodera.
This is Alex Smith.
And Alex, this one's been a long time in the making. Who do we have with us today?
Today we're delighted and honored to welcome Eduardo Bruera, who is, one of the biggest symptom management gurus, if not the biggest symptom management guru in palliative medicine. He's a palliative care doc and oncologist. He's chair of the Department of Palliative Rehabilitation and Integrative Medicine at MD Anderson Cancer Center. Among many other things, Eduardo created the Edmonton Symptom Assessment Scale, or ESAS, which is probably the most widely used symptom assessment scale in palliative medicine. Eduardo, welcome to the Jerry Paul Podcast.
Thanks. I'm so happy to be here. It's a great opportunity.
I am super excited because I got to tell you, pretty much every time I do a symptom talk to our fellows or our med students, inevitably I include one of your randomized control studies on this, from like IV hydration, from delirium to, the topic we'll be talking about is cachexia, kind of how we think about that, the meds that we use, to trials around delirium, and antipsychotics and benzos. So super excited. But before we jump into the topic at hand, we always have a song request. Do you have a song request for Alex, Eduardo?
Of course, CCR. CCR is from my time. And although they were born in your state, they sang about my part of the nation. So I would love to hear something from CCR.
And your part's Texas?
Absolutely.
That's right. So this song, we're going to do Midnight Special, which is from 1969. And I like this one because the introductory verse mentions food, and the second verse we'll do at the end mentions Houston, which is where the MD Anderson Cancer Center is. So I thought this was a nice fit. So here's a little bit of the verse and the chorus. Well, you wake up in the morning, you hear the work bell ring, and they march you to the table to see the same old thing. Ain't no food upon the table and no pork up in the pan, but you better not complain, boy, you get in trouble with the man. Oh, let the midnight special shine a light on me. Let the midnight special shine a light on me. Oh, let the midnight special shine a light on me. Let the midnight special shine an ever-loving light on me.
That was great, Alex.
That was fun. Love CCR. Thank you. Thank you, Eduardo.
We'll do a little bit more of that at the end.
Absolutely.
Eduardo?
All I can say is that the reason why I'm here is because I was a failed professional bass player. I did try CCR, but guess what? It wasn't coming out like that. Now, please be aware that this song is sang about a guy who's in jail. I'm not in jail. I'm in MD Anderson, and the food is probably as bad, but it's a perfect choice.
Well, I want to get on the topic of cachexia, but before we do, Eduardo, I got to ask, since you have been such a leader in our field in palliative care, I love kind of looking at the history of how people kind of went into the field and got interested in this. And you were one of the pioneers in palliative care, created one of the very first palliative care programs way back in 1984 in Canada. How did that happen in 1984? Because I'm guessing there wasn't a lot of palliative care going on back then.
No, they're right. There was no specialty. There were almost no programs. And basically, I trained as an oncologist, and I was shocked by the fact that we were focused on the biomedical aspect, and we were not even wanting to look at the person suffering experience. And so I got shocked. But but by seeing that we had so few resources and so few skills, and we were normalizing pain. And somebody said, "I hurts a lot, doctor." "Oh, that's normal because you have metastasis to the bone." But the patient would say, "Well, but it still hurts, though." And then we had people who were losing a huge amount of weight and getting very sad and so on. And we had no language. So I decided that that's really what I wanted to focus on, the person rather than the cancer. And there were no chances to do that where I trained. So I wrote letters at pre-internet era, and I got a great guy who was the director of a cancer center in Edmonton, Neil McDonald, who replied and said, "You know what? I think this would be nice. Come down here. Let's see what we can do. I'm the director of a cancer center, but I'm interested in this." So he brought me. He saved my life in a sense because the environment was very negative in cancer centers towards anything related to person suffering. But he was the director of that small cancer center, and he got my back. So when people went asking him for more X-ray machines or more beds, he said, "Yeah, I see you need that, and we'll try to find that out. But treat Eduardo nice." And that was what kept me being able to go for years. Then he moved on and then finally retired, but he paved the way towards me being able to do this type of work for many years. And so I'm always grateful to the initial times and also the people I came across for so many years who, like both of you, who do such a wonderful contribution to all of us by raising our morale. Yeah. When we're working in an environment where we're never very sexy, we need this type of push to make us feel that we're part of a community, we're part of a movement, and things are changing because we are around.
Well, I got to ask you this, because we also need a lot more of what you're very well known for as a trialist in palliative care, creating both assessments and thinking about how we actually manage certain diseases. Alex brought up the ESAS, the Edmonton Symptom Assessment Scale. Was that developed at this cancer center that you were mentioning in Canada?
Well, we had a palliative care unit in another hospital, but it was 5-10 minutes away. And basically, I saw that we had nothing to assess how the patients were feeling. So it was concocted in one of the nursing stations with a piece of paper and pencil. And we said, what are our patients suffering from as persons? Not because of their esophagus or because of their lung or because of their ovarian, as persons. And we came up with those 10 dimensions that needed limited change after, and it became very popular because it can be done in 1 minute. It's very simple. It's translated into 50 languages. And the most important thing is it has no copyright. Nobody makes a cent out of this. And I developed other things over the years, but I made my point that I get very well paid as a salary. I don't get pharma money. I don't get tool money. I don't get copyright of anything. And basically, I made it a point that this is for patients and this is for clinicians. And so whenever you see anything that we develop, you'll see that you'll always be able to use it without ever having to pay anything, because our goal is to do that. And the truth is, I don't want any patient or family to perceive that when Bruera goes to see me, there's a second interest, a second gain. Or when Bruera talks in a congress and says, "Oh, use this, use that." But there is no hidden agenda. I don't get any money from pharma, from copyrights, from anything. And basically, that's why I think you can do whatever you want with it and change it in any way you want. And I will be always very happy.
That's great. We hope that the creators of the mini mental status exam are listening. You who sold it to a company and now are charging people to use it. This is a much better approach. Thank you for that gift to our community and to the patients.
Yeah, I'm glad you bring that up, Alex, because I used it in 100 papers. The mini mental was the beginning of our work. And then one day I got a letter from a lawyer saying I had to pay $1 each time I used it. And I was shocked. So we did a public burning of that garbage. That, by the way, it was not really developed. Posting put together things that others had done.
Yeah.
And then we went to Bill Breitbart's MDAS, and we never looked back because Bill had the same philosophy. He made the MDAS available to anybody who wanted to use it, no copyright. And so I'd like to tell everybody who's listening or watching that there are multiple good ethical tools, and you don't need to pay for them. If they're asking you to pay for them, burn them and go to Google, and you will find free tools that are as good.
Well, let's go to the topic ahead, because one of the questions in the ESAS is anorexia. And anorexia and cachexia is, like, when I think about some of the pivotal studies, your name always comes up here. So I'm going to take it from the very, very top, because I think I know what anorexia is. Cachexia is one of those that kind of always confuses me. Like, how would I define it? How should I define cachexia and anorexia when I'm talking to fellow students or thinking about it in my own clinical practice?
Sure, Eric. I think the very simple practical thing is involuntary weight loss. When my patient is losing weight and doesn't want to lose weight, the patient is having cachexia. And I would never use BMI, because when I started working in this field, the BMI was about 5 or 6 points lower than it is now. We have an epidemic of BMI, and therefore never use the way the patient looks like to diagnose cachexia. And a patient might be looking very chubby, but lost 10, 15 pounds. That patient has cachexia. Yeah. And occasionally I get people calling me and saying, I see a patient who is very chubby, but their albumin is 2. Would they have a nephropathy or anything? No, that patient is dying of cachexia. It's just that they look like a big BMI, but they lost 15, 20, 30 pounds. They're not able to synthesize protein, and the albumin is a marker of that. So cachexia, I would put it, involuntary weight loss is the number one way to diagnose it. And
how important is that lean body weight or the muscle weight, the sarcopenia that we see? Like, how do you think about that? Is it just loss of, I guess, weight is hard because you can actually have a lot of fat weight, but actually lose that lean body weight?
Yeah. I would say the following. When you lose weight and then you have access to a CT scan in the L3 area that shows you the amount of lean body mass that you lost, or even a test like functional, like hand grip, and the patient is really, really low in that, that tells you that there is both function and structurally sarcopenia. And that is worse. So weight loss with sarcopenia is worse than weight loss with no sarcopenia. And sometimes sarcopenia happens with minimal weight loss because you're losing primarily muscle mass. So while losing muscle is what makes it a deadly problem, a killing problem, and it's not because of the muscle. It's just that because since you are having sarcopenia is a marker of the fact that you're not making antibodies, hormones, you're not synthesizing hormones that are necessary to survive. And as a consequence, you will unfortunately have a shorter survival. So weight loss, number one, if you can combine that with some understanding of how that patient is making proteins, even better, to fine-tune the real risk that is associated with the presence of the sarcopenia.
And I guess it's kind of hard because it's like overlapping Venn diagrams. So you have cachexia, sarcopenia, frailty also seems like it's moving in on that area too, at least like hand grip strength and the sarcopenia that we see with that.
The unintentional weight loss.
And unintentional. Then there's this weird concept of failure to thrive, like out there too. Does it matter that much what we call it, or just like we're seeing like the signs of cachexia, we're seeing the signs of weight loss, and that we should do an assessment and think about how we're going to manage it?
I think you're absolutely right. There's the Venn concept is wonderful, and I think you have body composition variables such as weight loss and hypalbuminemia and sarcopenia. Then you have body function variables, including hand grip, stand up and walk, and 6-minute walk, and all the functional variables that happen. And finally, you have what I think are the most distressing one as we get closer to the end of life, that are the symptom and body image changes, that are the ones that cause severe distress on this patient. And so these three have certain level of integration one with the other. What we do know is that the two ones, the body composition and the body function variables that you are describing under the term cachexia, sarcopenia, frailty, etc., really are associated with worse prognosis and with worse survival. And the other components of symptoms and body image are associated with suffering. And so that's why they become a very legitimate target for us.
I think we know the most with cancer cachexia. I think we don't know a lot about why it happens. Hand wave, IL something. But how should we think about why do people with cancer in particular, why do they develop cachexia? Is it just the anorexia, they're not taking enough in, or is there more to it?
I think in cancer, and similar to AIDS and similar to many metabolic diseases, including diseases like COPD, CHF, and so on, we do have massive metabolic changes in our body. Some of them are associated with inflammation as a reaction to the presence of the problem. Some are associated with toxic chemicals, tumor byproducts, insufficiency byproducts, and so on. And those get the body to become basically a flu. The patient is having a flu. And as a consequence of that flu, the person is not able to synthesize essential amino acids. It is unable to do lipogenesis and has symptoms that are secondary to it. And anorexia is one of the secondary symptoms. So the same as when you get a flu, you lose your appetite. You don't really get the flu because you lost your appetite. It's a symptom of that massive metabolic disarray. Now, what happens with the loss of appetite is that it is part of the flu, but if as a consequence of that we stop eating, we add starvation. So there's an underlying metabolic disarray, the big flu, and we lose our appetite as part of that syndrome rather than causing it. But once you get that, you aggravate that syndrome by adding a component of starvation.
I once heard you in Boston. I think it's PSEP, the course that...
Oh, yeah.
That's where I first met Eduardo, too, was in PSEP with Andy and Susan.
Yeah. Andy and Susan, at that time, they put us in that, that lousy hotel, or the other side where they already took us to the Royal Sonesta.
The Royal Sonesta. I was at the Royal Sonesta.
That was the fancy part. Several years before, we were across the street in a lousy little place close to the campus, and we complained so much that they finally took us the other side of the river, and that was classy. That was
a nice, classy hotel. I remember you had an analogy there. This is a long time ago for me, but something about a conveyor belt or an escalator. Does that ring a bell to you? I wonder if you could.
Yeah, well, I think that's an important point that helps us to decide what are we going to do in terms of aggressively nourish this patient. And what I try to discuss with my patients and also with colleagues that refer patients is when the metabolic factor is on strike, then you can bring all the wood you want, but you're not going to get furniture because the factory is not going to change that into furniture. And what keeps you alive is furniture. And so I can inject all kinds of amino acids and fatty acids and glucose into you, but that's not going to change things very much because what is killing you is the fact that you cannot use that material to synthesize the hormones, the antibodies, the cells that are important to you. And so the same thing happens with pushing food by mouth, by PEG, by TPN. When the factory is on strike, our efforts are aimed at trying to open that factory a little bit. Now, there are situations in which the factory is not completely on strike, is working a little bit, and the main problem is that there's no supply. I have profound dysphagia. I have a complete bowel obstruction and a very slow-growing tumor. There are situations in which the starvation component takes over. There, you can have some profit from bringing some material into that factory to improve a little bit the patient's well-being and body composition. So it has to be quite personalized, but the underlying problem with all these conditions, unfortunately, is that our metabolic factory goes on strike, and pushing a lot of material does not really get the success we would love.
Mm. So this is the hard part with anorexia and cachexia, right? Is that one, you know that there is let's say if the patient has cancer or severe COPD, that, the factory could go on strike or is going on strike, but there could be a lot of other causes for their anorexia from maybe they're just nauseous all the time from a medicine that we're giving them. Maybe that they're not taking anything in much because they got a big oral abscess. Maybe they're depressed. Maybe they have thrush. Maybe they're constipated. How does Eduardo Bruera think about this when he sees somebody with weight loss? What goes through his mind as far as the assessment that you're going to do to help figure out how much of this is just that the factory is on strike versus like some other component?
That's wonderful, Eric, because that's where we really can make a difference. We cannot very successfully open the factory. I mean, we can open the factory if the patient has a spectacular response to HIV management or to the cancer treatment. Then the main factors are removed. Unfortunately, in our side of the business, that's not that common. But what you're identifying are all those causes of what we used to call, and we still call it secondary cachexia. There are the real reasons why people are not eating or drinking enough to maintain their nutrition. And as you're identifying constipation, gastroparesis that happens in almost 100% of patients who are malnourished, and that the repulsive Sterner and Epic, whenever you want to prescribe metoclopramide, tell you that there's a whole bunch of interactions and there's going to be an explosion and you're going to go to jail, but it's the only drug that really is good at gastric emptying. So you find gastroparesis, you find chronic nausea, you find constipation, you find dysphagia, you find mouth sores, you find people who are unable to prepare their own meals, you find people who are lonely, who are depressed. Those are wonderful targets. Once you get into those targets, those are actionable targets, and you can really gain quite a few pounds. And also you give the patient some sense of self-efficacy by giving them not only the symptoms that are stopping them from eating and drinking, but also the sensation that there's some interventions from the nutritional and supplements and vitamins and so on that they can do that gives them a bit of a sense of control.
Yeah. Oh, I love that. Real quick, gastroparesis, metoclopramide, what, 10 TID-AC? What's your treatment for that?
Yeah, it's a very short half-life drug. That's the problem. And it doesn't last very long. So you have to take it right before the meals and perhaps PRN every 4 hours if there is more nausea or a sensation of fullness and so on. It's a drug that those who are old-timers, we used to use, to give an idea, before you give a shot of,
right?
2 milligrams per kilo 5 times, 10 milligrams per kilo. So a patient who is 70 kilos might get easily 700 milligrams of metoclopramide during the first day of cisplatin injections with some Decadron. And so I would say there is sometimes excessive concern about the use of these agents and use them at the dose they need. Recently, olanzapine has come to the rescue in some cases, and that has some effect, not necessarily on gastric emptying, but on a little bit more on appetite and food intake. And so that could be a nice around the clock and the PRN metoclopramide. But I still continue to use both, even though Epic advises me that there's going to be an explosion and I'm going to lose my license and everything else. That's something to have in mind.
Great. So any other kind of pro tips, Eduardo, pro tips on thinking about the assessment that you do for people with anorexia and cachexia?
Yeah, one of the things I try to do is to put it in perspective. How much is this bothering Mr. Smith? If Mr. Smith is having major existential, spiritual symptom issues, dyspnea, pain, I try to put that in a back burner, address those first, build a rapport with the patient, and then move on into the weight issues. And so, on the other hand, if the patient has horrible body image fear and concerns and thinks that the weight loss is synonymous of imminent death, or if the family are distressed, then it becomes a higher priority. So the first thing I try to understand is, where is this in this patient's agenda? And then the aggressiveness of the management might be dictated by, what else do I need to do for this person? If I need to work on mood, on fatigue, on dyspnea, on pain, on constipation, I would work on those first. And then see if in the next visit I made some progress in those areas, And now I can move into the discussion about the food and the supplements and so on.
Yeah.
I'm so glad you mentioned the family. I would say the social value of food cannot be overstated, and that for our patients, and particularly for family members, perhaps the number one concern I hear from family members is, my loved one is not eating. They're not eating enough.
If we can just get them to eat.
Yes. And then I'm interested in hearing the words you use to address that social anxiety, or, not just address, but reassure, but also recommend things like smaller meals, etc.
I think that's wonderful, Alex, because all our social and even religious events have metaphors of food. My daughter's birthday is I'm going to go tonight for dinner with the rest of the family. So the celebrations are around meals, the gatherings are around meals, and so there is so much that is lost when the person is not eating, when the person cannot eat. And then there's two components. One of them is the symbolic meaning of the meal as a social gathering, that I plead that they don't lose it, that they do not look at the plate, that they look at their loved one, and that they respect the willingness of the loved one to only eat 3 spoonfuls, not to fill up their plate in a way that they feel nausea before, anticipatory nausea by seeing their plate, but respect what they like to eat and to maintain the social value. So partially, I try to do a split discussion with that spouse or that family and say, hey, it's so important that you all get together, that you all discuss, that you all talk, that you all make all the social value. That from one area. From the other area, that is the actual content of the food, that is what is causing the person to die. I use a little bit the spiel of a factory on strike so that they don't feel that my loved one is dying of starvation. That would be a horrible feeling if my loved one was dying of starvation. And then I try to reassure them that this is not a matter of the person starving to death. It's a matter of the body not being able to use energy to create the substances. If I catch them before someone else puts a tube on them or puts an IV and starts TPN, much better. If the person is already on it, I wait and nothing will happen. And then after they tried it for a week or 10 days and nothing happened, I say, well, nothing is happening. So should we stop harassing your loved one with blood works and IVs and all that and things, because really nothing is happening? And then usually they say that's fine. We tried. And then we try, vitamins, particularly, the hydrosoluble ones go down quickly. So I try to encourage vitamin supplementation. I try to encourage amino acids, not so much protein, but amino acids, so that they don't have to digest them as much and they can immediately be used for some synthesis. And then food that packs ideally quite a bit of energy into it. And if I can use pharmacological also. The family usually takes some time to understand things. And I try to back myself up with some paper with some label, especially not so much me, but my colleagues who are younger than me, who might be assistant professors and so on. This is so counterintuitive, right? I mean, I lose my appetite, I'm not eating, I'm losing a lot of weight, and you tell me that food is not the answer?
Yeah.
I mean, you really have to have a lot of rapport and credibility on me to convince me that I should not be pushing this on my loved one. So it's nice sometimes to back ourselves up with some literature to support them.
So I got a question then around how much is like the multivitamin, amino acids, how much of that is just giving them something that is very low risk and hopefully low cost with the vitamins versus like a more evidence-based approach? Because to my knowledge, there isn't a lot backing up supplements, vitamins, especially using your analogy, because the factory is on strike.
You're absolutely right, Eric. I think one of the problems is that you do see an occasional kwashiorkor. You do see an occasional beriberi. You see an occasional massive weight loss that is associated with occasional hypovitaminoses syndromes. I usually won't measure them. I think it's very low cost and very low trouble to prescribe them. Usually patients like it because they're helping themselves. And so if they're just a placebo effect, I think I'm preventing some potential extra non-synthesis that is not happening because you're lacking that bottleneck little hydrosoluble vitamin that might be present. I try to emphasize D. If the patient is quite hypogonadic, I try to emphasize testosterone because they are conducive. They might be of some help. But you're right. The strength of the evidence is not that great.
Yeah.
But when you're losing an awful lot of weight and you're eating only, oatmeal, I think I have to suspect that the hydrosolubles are a little bit depleted.
And the amino acids, are you doing that as a supplement, or are you telling them to eat specific foods for the amino acids?
I do it usually as a supplement. The problem with specific foods is that, the person has a certain diet for 65 years, and now they have cancer. And now I tell them, we're in Texas, go eat kale. And then if you don't eat kale, you can eat arugula. And then the patient
And
says,
you can only get that in Austin in Texas, I heard.
Absolutely. You won't get that in Houston.
Yeah, everywhere else, they'll look at you strange.
So it's tough for them to have massive modifications at this stage. I'm talking about the later stage. The survivor is a different story. They have to really get on their wagon of improvement. But when the patient has very advanced cancer and they're not eating and they're cachectic, I try to emphasize doing the best they can with the diet that they are more likely to adhere to.
And where does exercise fit on? I know for fatigue, like cancer-related fatigue, exercise is a pretty good intervention. Is there a role when we're thinking anorexia, cachexia with exercise?
We believe there is. And we believe that I usually never call it exercise because my patients are my age, 60s, mid-60s, late 60s. And if they have not exercised for 30, 40 years, they are not happy when I tell them you got cancer. And now on top of that, you have to exercise. They say, well, I haven't done it. I mean, come on. Yeah. But what I tell them is, keep yourself physically active, go for walks, start working in doing on the pool, do house chores, keep yourself physically as active as possible. If possible, get yourself a little Fitbit or a little watch and count your steps and try to keep yourself physically active. We do know that is one of the most effective ways of treating your fatigue. So keep yourself moving. That electricity you make when you walk hits very good areas of your brain. And also, if you can, spend some time outside with no sunglasses and let that light go through your eye. Forget about the ophthalmologist's advice about protecting yourself from macular degeneration. Just go there, get light, because that also becomes electricity that hits very good areas of your brain. So those two can help fight the fatigue. My secondary gain on that is whatever the muscle doesn't ask, it won't get. So if the muscle is moving, the muscle will ask, and the little metabolic activity there is will deliver a little bit of energy for that muscle to rebuild. So there is a fatigue advantage, but I think there's also a sarcopenia advantage.
I love that analogy. Mm-hmm. Okay, I'm gonna move on to we talked about some non-pharm interventions, pharmacological interventions. You mentioned olanzapine. You kind of brought that up in the setting of like nausea, gastroparesis. Is there a role for olanzapine with cachexia, anorexia?
We think it's becoming to be a role because it's a funny drug. It can be quite problematic in people with diabetes and so on. But in reality, our patients have a lot of weight loss, and you can kill several birds in one shot. You have a little bit of an effect on insomnia. You have an effect on anxiety. You have an effect on nausea. It's a powerful anti-nausea, especially now it's been added to chemo, and it's beginning to be very effective at that. And it increases appetite. In fact, one of the main problems when it was used for patients with psychiatric conditions was the weight gain. Patients were gaining so much weight with olanzapine as compared to other atypical neuroleptics. And so there's something to be said about taking it regularly every night. I usually start 5 minutes at 5 milligrams at night. And that might be a kind of a reasonably well tolerated intervention. If my patient is on any sleeping pill or is in any anti-anxiety, it's a wonderful opportunity to get rid of those and put them on olanzapine at night instead.
And how much of that, because we'll be talking about like Megestrol or Megace, how much of that is just non-lean body weight increases that, what we see when we usually prescribe antipsychotics is it's not the weight that we want that builds up with these antipsychotics.
Yeah. I would say the following. It's clearly not probably the ideal weight, especially if the person is not moving around and so on. But I usually think that if you change the patient's feeling that they are rapidly dying because of weight loss, if you improve a little bit the way they look, because they're not looking as much because they got some fat back, that in itself might be a nice profitable investment. So I would say, yes, you're not going to get what you would love to get, that is a huge amount of lean body, but you're going to get something out of it that is, and also this feeling of anorexia can be extremely distressing. When people have no appetite, they know they're ill. And so the fact that you have, again, you look at a plate of food with some desire,
interest.
Exactly. That really is good for the morale.
Yeah, for the patient and for the family.
And since I brought up Megestrol, where are we with that? Do you still use that? Is that now out in favor of olanzapine?
I use Megestrol because it probably has a different mechanism of action. There's some appetite, but there's also genuine weight gain. And there's a debate about how much of that is lean body. But I think there are some studies suggesting that there is some lean body. If the patient has a clear history of DVT and thrombosis and so on, then I would probably try to stay away from it. But, in cancer, we've been massively attacked by the immunotherapy cartels. And the immunotherapy cartels have saved a lot of life. I have nothing against that. But many people who are in immunotherapy do not get saved by immunotherapy. Many patients stay on it for too long. And what the result of that has been that they've taken away the most effective symptomatic agent we've ever had, that are corticosteroids. And they help us with fatigue, they help us with anorexia, they help us with nausea, they're a good adjuvant for pain.
Our little magic palliative care bullet right there.
I always said, when I'm on call and they call me and they say the patient is having this or that, I'm thinking soccer, I'm thinking music, I'm thinking something else. And when the resident stops talking, I say, hey, is this patient on steroids? And when they say no, I said, that's easy, we can fix it. Then we'll think tomorrow, but we'll put them on steroids today.
Except if they're on immunotherapy.
Except when they're on immunotherapy, and they screwed my day because now I have to think about something else. But I think that's something to have in mind. The fact that this very powerful and effective drug is now, unfortunately, not available to us, brings us to alternatives that we had before. And Megestrol comes back as a potential option there.
And Megestrol is okay because it's a progesterone, right? It's okay to use in immunotherapy.
Well, don't tell me, oncologist. I mean, so far we got away with it. I hope there's not going to be some guy doing work there that will take it away from us. But so far that might be an option. Okay. There's a lot of things that are happening. For example, in breast cancer patients, when you put them on the new letrozole and many of the other agents, this is a terrible symptom. There are arthralgias, myalgias, massive osteoporosis, massive sarcopenia. It makes us wonder, where are we with hormones in general?
Yeah.
Males, I am very much into the fact that when you're really hypogonadic, clinically hypogonadic, I try to prescribe testosterone unless there's a huge contraindication for someone else. In female patients, I think the initial knee-jerk reaction against estrogen is starting to change. And so I would stay quite in touch with the literature and with the primary oncologist to decide, is this patient going to benefit from some hormonal replacement in selected cases? Because the hormonal deprivation is severe. And we need to remember that when we give the patients opioids cause hypogonadism, not just the cachexia. Opioids are a major cause of hypogonadism. So we need to know that interfering in that area might give our patient some benefit.
Well, I just want to say this is probably the chagrin factor at work, which was like something Alvin Feinstein wrote up a long time ago. You act on your last bad experience. I've had so many patients with blood clots on megestrol, that I stopped using it altogether because I just lost confidence in the drug. And I had so many negative experiences, it made me worried about it. I'm sure there are other listeners out there listening to this podcast who have had similar experiences. Anything you would say to them?
Alex, we stopped using it for a long time. We had other alternatives. We had corticosteroids, but many times we don't have them at this point. And I think that what happens with cancer patients die of three things. They die of clotting. They die of infection. Sometimes the subtle infection kills them, and they get hypotensive and they die. Or they die of arrhythmias and sudden death. Those are the three reasons why a cancer patient dies. And so there's no doubt that cachexia aggravates the risk for all those three. The patients do not die because of the cachexia. The cachexia increases the risk that those three will happen. There are other reasons, but those are the three main mechanisms.
What was the first one again?
They die from clotting. They die from
clotting. Okay.
Thrombosis, venous or arterial clotting. They die of infections, or they die of arrhythmia and sudden death. And those, regrettably, we do not have a good clotting, infecting, or heart arresting that we could measure in blood. We only measure tumor mass. That is very rudimentary to be able to tell us the risk for those events to happen. I hope that in the future we'll have the ability to detect who are the patients who are at an elevated risk for those complications beyond the events that we see. But one of the things we need to remember is that if I give someone a certain medication and the patient presents with a complication that is expected from the disease, I might create an association between those two. And it's something that we see a lot with many of the medications we use in cancer.
Yeah.
And so I don't know if you're getting called these days, but every other day I'm getting called because somebody has hypertension and they're on opioids, and they say the opioids are causing it. And I said, no, they're not. There are a dozen reasons why this patient is hypertensive, but please don't have them be hypotensive and in pain. I'm sure that if you put them in enough agony, their blood pressure is going to go high again because of the agony and the noradrenergic release of the pain. But there has to be another way to bring that blood pressure up. So we sometimes see that those associations, we need to understand that they might happen, but they're not necessarily causate.
And then when you think about anorexia, we were talking a lot about cachexia, anorexia, do you ever use, I don't know where Texas is with cannabis, but maybe Marinol instead, or we used to see a lot of mirtazapine. I know there's some mixed evidence now for that. Do you ever use either of those?
We used mirtazapine, and then the last two randomized controlled trials were disappointing. I have to tell you that before they become disappointing, we did not find that great response. Occasionally had a great response, but most of the time it was kind of mediocre.
Yeah.
With regards to cannabis, I worked with cannabis for a number of years, with Marinol, with THC and so on. And the truth is we never found anything very exciting. And so we ended
I got to say, Marinol is more disappointing than mirtazapine for me. I've never... And, I know people who smoke, who vape it with cancer, and they feel like they get much more than the Marinol, because Marinol is just THC, and there's a lot of other, it's probably the cannabinoids, I feel like, that are playing a big role.
We did randomized control trials. We didn't find much. Florian Strasser, who was my fellow, also did some, and I worked with him on that, and we did not find much. It was disappointing. Regrettably, I don't think there is that much going on with either CBD or THC at this point. We would love that be the case, but I normally don't prescribe it, because the other thing I want to remind ourselves is we have published about interaction between CBD and other drugs at the 3A4 level, and there is a cannabidiol gets eliminated by the 3A4 and another microsomal moieties, and then you might have an accumulation of one of the two. And also when you're at the pharmacodynamic level, when the patient is on opioids or other drugs, then cannabinoids are not that well tolerated. So we are all waiting for better products. We're waiting for better ways to get into the endocannabinoid system that might be more specific, perhaps. But so far, we are waiting.
I love that. And that kind of gets us into our song because CBD and all this stuff reminds me of CCR. But before we do that, Eduardo, if there's like one thing that you wish our listeners would think about or do when it comes to cachexia, anorexia, do you have like one main take-home point?
Yes, acknowledge that it's happening, validate the concern of the patient, and give them some tools. They are not great tools, but give them some tools because that will make them feel validated and that will build rapport. Yeah. Normalizing the fact that it's there, normalizing the distress is a great way to go.
And I love the idea. I still have that factory image is that factory may not be on complete strike. So it's important to think about all of these other factors that we may have a little bit more control over, like managing their nausea, managing their constipation, managing their depression, managing their loneliness. So I just love that analogy. So thank you, Eduardo.
Thank you.
Before we end, Alex, a little bit more?
Got a little more, starting with the line about Houston. If you're ever in Houston, well, you better do right. And you better not gamble, or you better not fight, or the sheriff will grab you, and the boys bring you down. The next thing you know, boy, oh, you're prison bound. Let the midnight special shine a light on me. Let the midnight special shine a light on me. One more time. Let the midnight special shine a light on me. Let the midnight special shine an ever-loving light on me.
Eduardo, thank you for being on the Jerry Pal podcast.
Thank you. Thank you for having me.
That was wonderful. And thank you to all of our listeners for your continued support. And we'd also like to thank our donors who've donated more than $250, including
Nina Flanagan, Penelope Thompson, Lloyd Woolstat, Mark Wren, Carol Heyman, Bob Rixey, Patrick Lally, Matt Schuster, James Tulsky, Annie Hargadon, Jeffrey Galbraith, Daryl Owens, Meg Walhagen, Susan Nelson, Sharon Bragman, Harry Hahn, Jessica McFarland, Victoria Braun, Diane Meyer, Mike Steinman and Dorothy Richmond, Wendy Peltier, Kelly Strait, Craig China, Ron Saber, Rebecca Goldstein, and Elizabeth Chung.
And again, those are the ones who've donated more than $250 in the last year. If you're interested in donating, click on the little donate button. Or if you just want to share our podcast on other podcasting platforms or Twitter or any other social media sites, that's good too.
And if I mispronounced your name, please shoot me an email. I will correct it the next time we record one of these. Thank you.